Okay, hey guys, I'm back after a couple of weeks with another part of the 2022 updates of myeloid neoplasms. So we had finished with MDS MPN, and now we have to move towards acute myeloid leukemias, the updates in that. This is a bit long, AML1, then I've broken it up into again those 10-minute lectures. Okay, someone had asked me to also mention what is important, what are the important questions that are asked in your MD exams in India specifically. So, right now, what I'm telling you or what we are discussing is important. This is the 2022 update WHO for lymphoid and myeloid neoplasms, and for an examiner who is aware of the hematology aspect or is keeping up with this, the hematology aspect of pathology, they will ask you the updates. In the updates, the most important part that you have to study for myeloid is MDS, MPN, MDS, MPN. In acute myeloid leukemias, the FAB classification was initially incorporated in the AML, that you have to study whatever the updates are there. Then the common mutation like 15, 17, 821, prognostic implication of that, what are the updates in that you have to know. In topics like mastocytosis, if you know the classification and the criteria, that is enough. Now, the way to study any malignancy, solid or blood, uh, by using WHO fascicle is that just go through those boxes of essential and desirable criteria, which were major and minor criteria before. Okay, just if you don't remember anything, if you can just remember those boxes. For instance, if I take example of renal cell carcinoma, then go through WHO fascicle of RCC. You can also go through Washington Manual of Surgical Pathology. You can also go through Sternberg/Ackerman, whichever you prefer. Fletcher's is there. Fletcher's, I used to read it as a reference. My textbook was Sternberg. My guide or kunji was Washington Manual of Surgical Pathology. And then there's a book by Gattuso, which is a differential diagnosis and surgical histopathology book, where they give you a lesion and then they give you a differential diagnosis to that lesion with all the important microscopic gross and points regarding molecular and IHC. So, for instance, it is RCC. Now, the latest WHO classification of RCC will be asked. Then you might be asked to give a gross and microscopic description of each entity. So, what you can do is make a table, write the names of whatever the WHO has updated, write two important gross points, two important microscopic points for each, and make notes like that. So you just have to go through the notes then. Endometrial carcinoma. The classification, molecular classification of endometrial carcinoma has been updated. So that will be asked. We don't use terms like simple hyperplasia with atypia, without atypia. All that has changed now. So you have to know. Yeah, that will be asked in Viva also. Mostly female genital tract, male genital tract, breast, the updated Gleason score and updated prostatic carcinoma. Recent advances 25 has something known as intraductal prostatic carcinomas. Fine. The difference between these high-grade pins, the Gleason's pattern I have told you, these are important questions. GIT, you will definitely, either in Viva or maybe in theory, MSI instability, CPG island hypermethylation in colorectal carcinomas, the two pathways, the MSI and the APC beta catenin pathway, then short May gastric carcinomas types, then polyps you should know, association with syndromes you should know. CNS glioblastoma multiforme slide is given usually in practicals. But again, the molecular and the IHC aspect of that is more important, because without that, you cannot classify a CNS tumor now, especially in practical reporting. Um, Breast, of course, carcinoma. How do you assess HER2/neu? ERPR HER2/neu panel. What are oncotypic DX? Kya hai? What is mamma print? All these things will be asked. Then, I mean, these are some important topics that are coming to my mind right now. Ovarian carcinomas, all of them. Sex cord stromal, germ cell tumors, epithelial tumors, everything, I can't help it, it is important. You have to know about them. Again, write the name of the tumor, write 2 points of gross, write 4 points of microscopy, make a table like that, and write IHC in the end, and just make those notes and just go through them every time. Benign hematology, molecular classification of thalassemia is always asked. Nutritional, they might give you a short note on lab diagnosis of megaloblastic anemias. Then they will, of course, AML ka classification they can ask, criteria to diagnose MDS they can ask. Then 5q deletion in MDS is important. Mm, Congenital dyserythropoietic anemia in IBMFs is important. Aplastic anemia is important. Then I think till now I can recall that, and I'll again tell you some important topics at the starting of the next lecture that I take. All right. So enhanced grouping framework, what has changed is there's more better grouping so that we can properly classify the genetic mutations, and number of blast पे जो emphasis होती है उसे थोड़ा सा down किया गया है. Separation of AML with defining genetic abnormalities from AML defined by differentiation, that is the FAB criteria and the genetic mutation criteria separate. Elimination of the 20% blast requirement for AML types with defining genetic. So if you have a proper like mutation, SEPA, BCR, ABL1, then even if you have 5 blasts, it is still AML. AML with other defined genetic alterations, a landing spot for new and uncommon AML subtypes that may or may not become defined types, means since they are grouping more based on genetics rather than morphology and blast count, so probably you'll get some more varieties of AML rather than the common ones 15, 17, 8, 21, inversion 16, 9, etc. You might get some more molecular mutations in AML in future. However, it is not sure whether they'll stay in the classification or become irrelevant. So, defining genetic abnormalities: PML RARA, RUNX1, CBFB, DEC, RBM15, BCR-ABL, KMT2A, NPM1, cup-shaped blasts are seen, cup-shaped nucleus of the blast. SEPA, MDS-related AML has come under genetic abnormalities. All right. And defined by differentiation: AML with minimal maturation, without maturation, with maturation, acute basophilic leukemia, myelomonocytic, monocytic, erythroid, and megakaryocytic. So this basophilic leukemia is something that you normally did not remember when you were reading some other book, but WHO has this as an entity properly now. Okay. So AML with recurrent genetic abnormalities, increased recognition of importance of high sensitive MRDs, means sometimes you get AML, morphologically you're not getting blasts or flow cytometry, but still the AML recurs. MRD is okay negative, but the AML recurs after some time because of the genetic abnormality. So in those cases, we either go for very, very sensitive techniques to actually detect the MRD, or be very, very cautious that if there's an AML with recurrent genetic abnormality where you're not getting an MRD or morphologically appearing in remission, you have to think twice, assess clinically, and then go ahead. And the impact of concurrent molecular alteration reflect factors that impact patient management and therapeutic decisions. AML with BCR-ABL1 and SEMPA mutations are only disease type with defined genetic abnormality and require at least 20% blast diagnosis. So rest all those lists I read, even if 5-6 blasts are there, you can call it AML. But if it is BCR-ABL1, because that is also seen in CML, and SEPA mutation, you need 20% blast. The blast cutoff requirement is needed for the former to avoid overlap with CML, as I said. Distinguishing AML with BCR-ABL with initial myeloid blast phase of CML can change the treatment. Pre-AML types with characteristic rearrangements involve CUMTA2, MECOM, and NUP98. Blast count under 20% is acceptable based on studies demonstrating that patients with less than 20% blast, initially MDS, and any of these mutations have clinically features of high blast count. What it means to say is that in such mutations, except BCR, ABL1 and SEPA, we see that clinically this patient behaves like an AML or worse. So if the blast has not yet reached 20% and you leave these cases, not calling them leukemia or giving them a leukemia, subleukemia, whatever, but not treat them like a proper AML, then this can become bad for the patient. That is why everything is now becoming molecular and genetics rather than just pure morphology. AML with KMT2A rearrangement is a new term that replaces 9/11. KMT2A, MLL, T3, this is was there existing, but now it is only known as KMT2A rearrangement. Adult patients often present with high blast counts, usually with monocytic differentiation. Now, this all you will have to remember. Make a chart. Mutation, morphology. At least the important ones like SEPA, like BCR-ABL1, like KMT2A, like NUP98, like MICOM. You make a chart for that. In children, AML with KMT2A, MLLT3 or MMLT10 show megakaryoplastic differentiation. In adult, is known as KMT2A mutation. Predominantly, it is known as KMT2A mutation. Now, this can go along with other mutations also, but we do not take their names regularly now. But we do find them. Like we still find MLLT3, we still find MLLT10. So in children, if you get a KMT2A, it is mostly megakaryoplastic. In adults, it is mostly monocytic. This approach aligns data showing that cases previously classified as MDS, MDS-MPN with NPM1 progress to AML. Just to eliminate this overlap, कि हम एक कम blast count के case को we are just keeping it in MDS and not giving it AML, and within 6 months this case becomes AML with a bad prognosis. We are trying to catch. Look, the crux of any diagnosis is you need to catch the cancer before it can kill the patient. All these classifications are made for that, be it solid tumors, be it blood, hematological malignancies. If there is something which is impending an early diagnosis and it is being consistently seen that that case progresses into something bad, then we change the classification. So initially we are having a case where the blast is 5%, 10%. The patient behaves like an acute leukemia. However, when we cannot keep it into AML because the cutoff criteria is कि जब तक 20% नहीं होगा हम नहीं बोल सकते acute leukemia. Then we analyze the mutation. We see that a particular mutation is occurring in all those cases. So now we have revamped. We have taken it out from criteria, those cases like MDS, and put it in AML if the mutation is proven. Definition of AML with SEPA has changed to include biallelic. Initially it was monoallelic, as well as single mutations located in basic leucine zipper B-zip region of the gene. There's a zip, they are coding and non-coding and then zipper regions a little too much. Just remember that biallelic SEPA is there. The favorable prognosis associated with this combination has been demonstrated in children as well as adults. RUNX1 mutation in AML overlap with such broad range defining molecular features that it is determined to lack enough specificity. You know, RUNX1, not much important. SEPA, NUP98, CUMTA2A, NPM1, these are the important ones. So cytogenetic and molecular defining AML, MDS related AML has also come under this now. Remember that. Defining somatic mutations. So what are the cytogenetic abnormalities? Complex karyotype greater than 3 abnormalities. Monosomy 7, 7q deletion, loss of 7q, 5q deletion, loss of 5q, 11q, 12p, monosomy 13, 17p, isochrome 17q. These were there before IDIG X Q13. What are the somatic? This is important. Somatic mutations are ASXL1, BCOR, EZH2, SF3B1, SRSF2, STAG1, and this list you need to remember, especially this one, the cytogenetics. AML with myelodysplasia related changes, DML, now called AML myelodysplasia, initially known as DML, now known as AML MR. पहले AML जिसमें MDS like changes थे, DML कहलाता था, अब AML MR. It has 20% blasts से ज़्यादा, expressing myeloid immunotype and harboring specific cytogenetic and molecular abnormality of MDS. It is de novo or a previous history of MDS-MPN is known. What are the cytogenetic abnormalities? I told you before. Complex karyotype, isochrome 17q, 5q deletion, unbalanced loss of 5q, 7q monosomy, deletion 7q, unbalanced loss of 7q, 12p, 17p, those. Fine. Removal of morphology alone as a diagnostic premise to make diagnosis of AML-MR, a good point. Cytogenetics is important. They have updated the cytogenetics and introduction of somatic mutations, SRSF2, SF3B1, U2AF2 in more than 95%. ये add-ons हैं. The cytogenetics update हुआ है, somatic mutations add हुए हैं, and only morphology has been removed. And then a new criteria for AML with MDS related changes has been introduced. Then AML defined by differentiation, BCL11B rearrangement in mixed phenotypic or myeloid, ETPLL, acute leukemia of ambiguous lineage, and a subset of AML with minimal differentiation is a biological continuum across these means in MPAL, in ETPLL, in ALL with ambiguous basic lineage, one mutation that is constantly seen is this. So this proves that all these entities MPAL, BPAL, ETPLL, etc. are related somehow. Okay. Diagnosis of AEL supersedes AML-MR, de novo AEL, and cases that arise following MDS-MPN share distinctive morphological features with what is AEL? Acute erythroid leukemia. If you are getting a case with 20% blasts which are looking erythroid and there is dysbiosis, don't call it AML with dysplastic related changes, because MDS affects erythroid a lot. Call it AEL because prognostically AEL ज़्यादा खराब है, so it is better to treat AEL than MDS MR. De novo AEL and cases that arise after MDS share distinctive morphological features with prominent pro-erythroblastic proliferation. Fine, so this pro-erythroblast gives resistance to treatment, and you are labeling something like RARST, refractory cytopenia, refractory anemia, MDS-M. No, it is AEL, treated as AEL even if it is not 80% blast. If there is erythroid lineage blast, just treat it as AEL with dysbiosis. AMKL, 3 clinical groups: Down syndrome children, without Down syndrome, and adults. Immunophenotype, detection of markers for megakaryocytes are required to make a diagnosis of AMKL and detect the, now what is new? RAM immunophenotype. And this correlates with this gene. Fine. And this is a type of genetic alteration. That is all that we know about RAM immunophenotype in megakaryocytic leukemia. That's all that we know about it. Okay. And then myeloid sarcomas, this is the last slide. Relevant gene mutations are detected in a subset of patients with morphologically normal appearing marrows, suggesting low level of clonal myeloid disease or CH in the bone marrow. So what is the summary? AML is arranged into two families with defining genetic abnormality and defined by differentiation, and AML NOS is no longer applicable. Most AML with genetic abnormalities should have or can have less than 20% loss. AML-MR replaces the term AML with myelodysplasia related changes. AML transformation of MDS and MDS-MPN continue to be defined under AML-MR. Okay. AML with rare fusions are incorporated as subtypes under AML with other defined genetic alteration, like I told you right now. Fine, RAM mutation. AML with somatic Lennox mutation is not recognized as a distinct disease type due to lack of sufficient. Every genetic abnormality wants itself to be, distinct. That, if it is NPM1, it's good. If it is SEPA, it's good. If it is FLT3, it's bad. रनक्स का कोई ऐसा नहीं देखा गया है नए क्लासिफिकेशन में, so it is just AML with one mutation. Prognosis is same like any other AML. So next, I'll be taking AML with ambiguous lineage leukemias. I hope you could understand some part of this, and again, I'll tell you some important topics in the next session. Okay.